Hi, my name is Rick Sasso. I'm the president of the Cervical Spine Research Society. On behalf of the board of directors and all of the members of the Cervical Spine Research Society, we would like to share with you this educational video that will help assist you, your anesthesiologists, your recovery room nurses, and all of the medical personnel who help you care for your patients after anterior cervical spine surgery. This streamlined approach to the evaluation and management of potential airway compromise after anterior cervical surgery is a rational step-by-step algorithm to efficiently secure the airway with a retropharyngeal hematoma. I thank my fellows, Drs. Ryan Snowden and Tyler Jenkins, who you will hear in the upcoming video. I also thank Dr. Gregory Schroeder, who is the Cervical Spine Research Society Chairman of the Special Projects Committee. And I especially thank Dr. Alex Vaquero, the past president of the Cervical Spine Research Society, for his unwavering support. We believe this streamlined approach will benefit you and your medical staff effectively manage the very rare but potentially catastrophic outcome of retropharyngeal hematoma after anterior cervical spine surgery.
Thousands of anterior cervical discectomy infusions are performed yearly in outpatient surgery center. This is the most commonly performed operation to treat symptomatic cervical pathology. ACDFs are performed on an outpatient basis to improve patient outcomes and reduce the cost of care significantly when compared to inpatient hospital stays. When done in an outpatient setting, ACDFs are extremely safe. In a study by Dr. Sasso and Dr. Guaranter, over 600 ACDFs were performed with a significant complication rate less than 1%. Requirements for outpatient ACDF are fairly strict and require that patients be observed for 4 hours postoperatively. They also require a significant and thorough neurologic exam prior to discharge and are only discharged home if the patient has the support of a competent adult caretaker. We also recommend surgery center adherence to the no strikeout protocol, which we will discuss later in this video. We also would like to identify risk factors early in patients that would be at risk for postoperative retropharyngeal hematoma. Risk factors include ossification of the posterior longitudinal ligament, longer surgery time, and multiple levels. This is the typical approach performed during an anterior cervical discectomy infusion. Typically there's a horizontal incision on the front of the neck. This is closed with a subcutaneous monocryl suture that will be encountered upon initially opening the incision. The platysma is a thin layer of muscle which is often closed underneath this. This can be opened as well using a hemostat. The finger is then inserted into the plane shown above, where the hematoma can often be palpated and evacuated. Here's a CT scan demonstrating a retropharyngeal hematoma following anterior cervical surgery. On the right, with the asterisk, is the large hematoma, which is displacing what is typically a midline structure of the larynx, as seen with the plus sign. Following evacuation of the hematoma, we again want to be able to recognize the appropriate landmarks for placement of an emergency cricothyroidotomy if necessary. The most prominent and palpable area is the thyroid cartilage, also known as the Adam's apple. While running the finger along the anterior portion of the neck towards the chest, a small divot or valley can be felt that is soft compared to the thyroid cartilage. This is where the cricothyroidotomy site would be done, also known as the cricothyroid membrane. Below that is the cricoid cartilage, which is the last ring of cartilage which can be felt in the anterior aspect of the neck. Our no strikeout anterior cervical airway management protocol is a streamlined protocol for patients that have undergone anterior cervical discectomy infusion as well as other anterior cervical spine surgeries. This has been developed based on available ASA guidelines, literature, and extensive experience performing outpatient cervical surgery. The events leading up to initiation of the strikeout protocol may vary. In patients who have undergone anterior cervical surgery, signs such as difficulty and worsening of breathing, increased swelling of the anterior neck, and even deviation of the trachea may present if there is a retropharyngeal hematoma present. We encourage staff to involve the anesthesia and surgical team early in the course of treatment if there is concern for impending airway compromise. However, once the decision is made to initiate the no strikeout protocol, The team should move quickly to alert the appropriate staff, have the crash cart with tracheostomy kit at the ready, and also alert the operating room should the incision have to be opened so a formal expiration may be done once the airway is secured. Following initiation of the no strikeout protocol, the initial step is to attempt an intubation. This may be difficult, however, if there is significant tracheal deviation or swelling secondary to retropharyngeal hematoma. The second phase is an open sweep of the surgical site. Standard PPE gloves may be utilized for this. The incision is opened either by hand or spread with a blunt instrument, and the hematoma is digitally removed. Once this is done, a second attempt at intubation may be attempted. If this attempt fails, we consider this strike 2. At this point, we would proceed to the emergency tracheostomy, which we will demonstrate the technique for in this video.
So after the no strikeout airway protocol has been initiated, the anesthesia team will first attempt an intubation in a normal fashion. If they fail this technique, the assistant to the anesthesia team member should remove the surgical dressing that is present in anterior cervical spine surgery. This will make present any relevant anatomy. At this time, you might want to look for localized swelling at the site of the incision, look for fullness, and then the airway, pharynx, and anatomical components may be visualized. This is the thyroid cartilage. This is the cricoid cartilage. The area in between is the cricothyroid membrane, which is where you will make your incision for a cricothyroidotomy if needed. After the anesthesia team fails the initial intubation, that is strike 1, the assistant will move on to the next step of the procedure, in which the surgical incision is opened. The first layer of an incision is usually a running stitch, and this can be opened gently with a hemostat agent. You will see that the incision is now open. The key component is next a finger sweep, in which the assistant puts their finger directly behind the esophagus and the trachea and directly under the spine and sweeps the finger down to open the cavity to allow drainage of any blood that is present. At this point in time, the anesthesia team member can again attempt intubation. If intubation fails on this attempt, this is strike 2. Since there are no strikeouts allowed in anterior cervical airway management, we now move to the cricothyroidotomy. We will expose the anterior surgical incision to the point that we can feel the cricothyroid membrane. We will then obtain our cricothyroidotomy kits either via 2 manners. 1, the material contained in the crash cart, which we will show you here, or 2, via the supplies on the anesthesia typical table in the operating room. First, the crash cart. Feeling directly between the thyroid cartilage and the cricoid cartilage, the assistant can make a stab incision in the cricothyroid membrane.
Here we have a prosected cadaver with an incision centered around what would be typically 5-6. We're easily able to identify the thyroid cartilage once the incision has been split. The cricothyroid membrane is then easily identifiable and palpable. If during a cricothyroidotomy the decision is made to place an incision through this membrane, a transverse incision can be easily created and then spread with available blunt instruments.
At this point in time, once this hole is present, a guide with an endotracheal tube can be inserted directly into the airway. This will pass easily without resistance to the surgical incision. The guide can then be removed, and then the endotracheal airway can be established with a bag mask ventilator. The other option is if this is not present and you are in the anesthesia room, you can use the bougie on the anesthesia kit. Similarly, make a similar incision in the cricothyroidotomy membrane. And then use the bougie to gain entrance into the pharynx and trachea. And then using this as a guide to place the number 6 endotracheal tube, which is present on all anesthesia tables. The balloon is then inflated with a syringe. The bougie guide is removed. And the airway is kept patent. And the bag vat mask is used to ventilate. At this point in time, the patient would be taken to the operating room, and the surgeon would perform a surgical exploration, hemostasis, and irrigation is necessary.
The Cervical Spine Research Society hopes that this streamlined algorithm helps you and your medical staff manage this potential complication of retropharyngeal hematoma after anterior cervical spine surgery. Please take this video and show it to your anesthesiologists and recovery room nurses. Consider this part of our culture of safety. Consistent with this culture of safety, the CSRS appreciates your feedback and suggestions on how we can make this better. Please voice your opinions on our website. Thank you for your time and attention. On behalf of all the members of the CSRS, we wish you a good day.